Vitrectomy for rhegmatogenous retinal detachment involves several key considerations. In this case, the patient presents with vitreous hemorrhage and a history of diabetes mellitus. It's crucial to differentiate these conditions, as acute vitreous hemorrhage can often mask hemorrhagic posterior vitreous detachment, which in up to 70% of cases may coexist with a retinal tear. I always advise starting with anterior vitrectomy to remove as much anterior vitreous as possible. In cases like this, unlike others I have shared previously, it's essential to eliminate as much vitreous as possible. Remember, that's a significant part of why we are performing the vitrectomy in the first place. Now, here's the case: a total retinal detachment with a slightly bullous appearance. Now, in such cases, what I do is to start with a slightly cold vitrectomy and then direct the vitrector to the area where the tear is, and then aspirating as much retinal fluid as possible. That will help me to flatten the retina and serves as a safety net. This will provide greater stability before proceeding with the vitrectomy, especially when there is a tractional component of the vitreous in the mid-peripheral area. In other scenarios, you may begin the vitrectomy away from the detachment, but here that's not an option. Now observe how aspirating the subretinal fluid flattens the retina, creating space to safely complete the cold vitrectomy and subsequently perform peripheral vitrectomy. As I mentioned earlier, in these cases I am meticulous about removing as much vitreous as possible. In these cases, when you are performing the shaving or the vitrectomy in the peripheral retina, where the vitreous can be more adherent and the retina is slightly more mobile, are advised to perform a high cutter rate and a low aspiration flow. There are some instruments that can program the vitrectomy step by step, and you can choose personalized or shaving vitrectomy in these scenarios. Now, the peripheral vitrectomy or the shaving must be very good at the area where the tear is. I usually cut the flap of the retinal tear. This will allow me to verify or be sure that there is no remnant traction in this zone. Now, as you can see within the detachment, there are some intraretinal folds. There is no significant BRP, and the retina is quite mobile, which is a good sign. Now, a useful tip is always to mark the tear with diathermy. This helps to keep track of where it is in the subsequent steps, particularly when flattening the retina. Prime alone is always good to verify that there is no remnant of the posterior alloid. This is always a step that I perform in all my retinal detachment cases. It seems there has already been a posterior vitreous detachment here. There are some triamcinolone deposits at the posterior pole. I always verify with a soft silicone tip whether these are not part of a membrane or a complete alloy layer. Typically, when these spots are aspirated separately, as you see in the video, and there are no band formations within the triamcinolone, and also especially when the peripapillary area is completely free, it's a good indicator that you won't need to chase a posterior alloy. Indentation 360 degrees is always a good choice, especially in these cases, to verify that there is no other retinal holes or tears that are causing part of the problem. The next step is crucial: shaving the vitreous base. Yes, I know I have emphasized this many times, but truly, removing as much vitreous as possible in these cases is paramount. With the help of your assistants or your surgical team, you can use indentation to eliminate the remnants of the vitreous periphery and the vitreous base as much as possible. This step takes the most time during surgery for me, and it's where I invest the most effort, because only by doing this I can effectively reduce the likelihood of inflammation, vitreous contraction, vitreoretinal proliferation or VRP, and ultimately a recurrent retinal detachment. Now, during the next step with the diathermy, I mark the area where I will perform a retinotomy. Usually I do it in the posterior and nasal retina. After I mark with the diathermy, I aspirate gently with a soft silicone tip with the extrusion mode in order to complete the retinotomy. Now, why I do the retinotomy in this case? There is only one tear, and this tear is located very superiorly and in a slightly uncomfortable position for aspiration with good visualization during the fluid air exchange. Having this retinotomy will allow me to have a second point of extraction of subretinal fluid later on in the surgery. Now, perfluorocarbon liquid has been applied into the vitreous cavity and the retina has been flattened very good. The next step will be to put laser around the retinal tear and around the retinotomy that I performed earlier. There is debate outside whether to put laser only in the retinal tears or 360 degrees in all retinal periphery. I believe doing it only in the retinal tears is more beneficial, especially because I have seen some cases where you apply laser and you create micro holes in the periphery, and these are the reason for a recurrent retinal detachment. So in these scenarios, always less is better. Here I perform some indentation in order to reach the anterior part of the retinal tear and be able to surround it with laser. You can of course move to the next step, which is the fluid air exchange, in order to see better the retinal periphery, but I believe that once you reach the point where the retina is flattened, even if it's under perfluorocarbon liquid, you can apply the laser with no more delay. Now, the next step is the fluid air exchange. In this phase of the surgery, you need to remove first all the fluid above the perfluorocarbon liquid and then direct the extrusion tip at the level of the retinal tear. And once the liquid exceeds this level, you can continue removing the remnant of the perfluorocarbon liquid at the posterior pole. At this step, you can realize why I created an accessory retinotomy. This allows me to have the possibility of aspirating much more easily any fluid that I have not been able to remove, especially at the initial part of the fluid air exchange. As you can see, the retina looks perfectly attached under air, and at this step you can also consider to apply more laser around the retinal tears. This also helps to verify that there is no subretinal fluid around the holes or tears, and also that the retina is perfectly attached. If you have laser marks, it means that there is a good contact within the neurosensory retina and the RPE. If there are no laser marks, it means that there is still some subretinal fluid and you need to drain a little bit more. Once that you verify that the retina is perfectly flattened and attached, the next step will be to apply the intravitreal gas. In my opinion, C3F8 between 12 to 16% concentration is ideal for these cases, and basically that's the end of the case. Finally, don't forget to check our IQ point of the week, where you will find a lot of good info about these cases. As always, thank you for watching.